Yeah, I finished the last of my hours day before yesterday. So I'm really excited about that. I'm going to share a little presentation on the support that we give to breastfeeding women. My introduction to working with mothers and babies was about 4 years ago. I started working as a postpartum doula. This is the first baby that I took care of, and I took care of about 26 babies for usually 2 to 6 weeks at a time, mother and baby, obviously. And through that time, I grew up in a culture of breastfeeding. My mom breastfed me until I was 2. My other siblings each got breastfed till they were 2, and my sister got 3 years. So I grew up in that culture, but I didn't realize how challenging it was for women to be able to breastfeed. And so through that, staying in the homes, helping them, I realized, wow, there's a lot of things that I want to learn to be able to serve these women better. So this was the beginning of that journey. This is the CDC breastfeeding report card as of 2015. 83% of American babies started out breastfeeding. 57% of them were breastfeeding at 6 months, and 35% of them were breastfeeding at 12 months. However, that wasn't exclusive breastfeeding. Some of that was token breastfeeding, just sometimes breastfeeding. Exclusively breastfeeding, less than 50% of babies get to be breastfed till 6 months, and by 3 months, 25% of them are actually still exclusively breastfeeding. So these rates suggest that mothers may not be getting the support that they need, both by healthcare providers as well as family members in our culture in general. So there's a lot of studies that have been done to see the effectiveness of breastfeeding support. The Cochrane review went over lots of different studies that had been done. There's a couple studies that I just pulled up here of interest. In France in 2005, they did a study where a control group just got conventional care. The other group got a 2-week follow-up with lactation support. And they got to, the women were able to breastfeed their babies an average of 5 weeks longer as a result of 1 lactation visit. So really, what we can do as lactation consultants, as nurses working with mothers and babies, really can make a huge impact. Another study in Canada saw 22% increase of breastfeeding at 3 months as a result of follow-up from peer counselors. And those aren't even medical professionals. Those are just people who they're saying, I'm here to support you. What kind of questions do you have? What are your problems? How can we support you? So breastfeeding support is huge and really makes a difference. However, it's interesting to note that not all breastfeeding support is actually helpful. This is my cousin. She sent me pictures for this presentation. She's currently breastfeeding her 3-year-old and her 2-month-old. And so she's very committed to breastfeeding. She's tandem nursing, as they call it, where she has her 3-year-old and her newborn breastfeeding at the same time. Right before I began this internship, I was telling her that I was studying to be a lactation consultant. She's like, she was telling me that she was struggling with latching her new baby. Her new baby was 3 weeks at the time, and just the day before, she had gotten to see a lactation consultant to help with latch problems because she was having sore nipples that were kind of ongoing, and her baby was having some upset stomach issues that she thought might be linked to swallowing too much air or something. And she told me, I paid all that money and I went to see the lactation consultant, and I walked out of that room and I felt less competent at breastfeeding my baby than I did before I went in that room and before I saw that lactation consultant. And I said, that's really disappointing. You breastfed a 3-year-old for 3 years, and now you've got a new baby and you're breastfeeding, you feel less confident than you did before seeing that lactation consultant. That's really disappointing. So there's been a few studies. Obviously, they would like to do more studies on the effectiveness of breastfeeding and what we can do to make that support better. This is study that is fascinating, and if you are working with mothers and babies, definitely I would encourage you to read the whole study that was done here. It's called Mining for Liquid Gold, Midwifery Language and Practices Associated with Early Breastfeeding Support. So it uses the word midwife because in this study, it was midwives in Australia who were doing the care for breastfeeding support. So some of these midwives were actually IBCLC lactation consultants. Some of them were not. Within the study, they had 77 women who consented to participate. It was the discourse between the mother and the lactation support was all recorded and transcribed and then studied afterwards, as well as the researcher observed the interactions visually as well. And they brought out 3 distinct approaches that they were able to kind of observe and break down. One approach was mining for liquid gold. This was actually the dominant approach. And I think it grows out of like a medicalization of breastfeeding. We've done so many studies that show that breastfeeding is just the best possible for babies. And we do studies on the impact of it on preventing disease and the value of colostrum in those early days. And so in some sense, lactation becomes kind of a medicalized, where we're worried about getting that liquid gold for the babies, and we sometimes forget that the breasts belong to the mother, and that breastfeeding is a very emotional interaction between mother and baby. And so in this approach, they would see the midwives or lactation consultants going in and just picking up the baby, latching the baby, doing all the work for the mother. And sometimes they didn't seek consent. Is it okay for me to touch your breast? Is it okay for me to touch your baby? It was just assumed that because the baby needed milk, they could just put that baby on the breast. It was also seen in this approach that the midwife was the expert. She knew all about breastfeeding, and she could teach this mother how to use her breastfeeding equipment. And so it was just a very medicalized approach. It was seen by the midwives that it was easier to do for the women than to teach them how to do for themselves with their baby. They also relied very heavily upon equipment, which obviously we see the value of breast pumps, we see the value of nipple shields, we see the value of some of these tools, but sometimes there's almost a thought that let's just jump to a solution here rather than listening to what the mother and baby are telling us. So there was another approach, and it's interesting, you know, when I went through the study, I was like, wow, I see myself doing some of these same things, you know, as I do this internship, because we have so many mothers and babies that are relying on us for care that we kind of have to just jump from one to the next. So this is another approach. Breastfeeding, it's not rocket science. It's the idea that if a woman is committed enough to breastfeeding, she will breastfeed, and if she's not committed to it, she won't. And our help doesn't really make a big difference. And we see that happening, you know, sometimes in this hospital, where it's just kind of a quick interaction with the mother and baby. Well, she's not real committed to it. She's not trying hard enough, so I'm not going to help her too much. And a lot of times in this approach, the midwives were very quick with the mothers and didn't give them time to really express themselves, express what they were going through. The third approach, which unfortunately was the least observed, but definitely the most effective and the one that the women really reacted the most positively to, was the idea that breastfeeding is a relationship. It's a relationship between the mother and the baby. And it was very women-centered, mother and baby-centered. Women were considered to be knowledgeable about their own needs and those of their baby. The midwives facilitated communication and built confidence. They provided suggestions and ideas, but avoided merely giving instructions, telling them what to do. They were recognizing that each mother and each baby was different, and their goals might be different, and so they provided a lot of ideas, but didn't tell them what they had to do. They initiated their interactions with a friendly chat, talking about things besides breastfeeding. You know, how was the delivery? How are you doing? How are you feeling in this transition into motherhood? And that really offered the opportunity for the woman to just open up and really share what she was going through. Open-ended questions and empathetic listening, genuine support. They took the time. They shared their experiences. So that breastfeeding relationship really allowed the women to open up. They also put an emphasis on getting to know the baby. The baby is an individual. They were trying to show the women that they were, you know, the baby was wanting to learn to breastfeed. And so sometimes women will have a negative view of this naughty little baby just won't latch. And so they would take the time to counsel with the woman and just kind of talk out, you know, your baby's learning to breastfeed. See, your baby is massaging your breast. See, your baby's licking and smelling your nipple, you know, thinking about latching. And so they were able to help the women bond with their baby, and breastfeeding became a bonding experience for them. So some of the studies that I looked over talked about some of the reasons that women don't access support. For example, with my cousin, she had sort of a negative experience with that lactation consultant. Was she going to go back and see that lactation consultant? No. And if she wasn't as committed to breastfeeding, she might not have gone to seeing someone else who actually did help her in the end. So sometimes women don't access support. One of the reasons in the study that they shared was that some women felt like the midwife was too busy and they didn't want to use that scarce midwifery time. And the ones who are least assertive were the women from the lower socioeconomic occupational groups, which is interesting because who are the women that breastfeed the least here in America? It's those from the lower economic groups, and so they're the ones that we need to give the most time to help them overcome that disparity. The women reported that the rushed encounters were perceived as unhelpful. They didn't feel listened to. It was just a blanket answer or a blanket approach. There was also another study that was done that talked about how breastfeeding supporters talked about rules. There was this rule and that rule that the women had to keep in order to effectively breastfeed. And if they broke those rules, those women didn't feel like they were eligible to go seek support after that. Whereas if it had been approached, given that breastfeeding was a relationship, I think they would have felt like they could go and get support because it wasn't a rule-based situation. Breastfeeding support groups can be really helpful later on, but it was in the studies that they did, many women are intimidated by breastfeeding support groups. They don't want to haul their 5-day-old to a breastfeeding support group and be watched by a bunch of other women. They want to be cared for within the privacy of their own home or in a private encounter. So kind of in recap, these are some things that a lactation consultant or nurses who are working with breastfeeding mothers can do. They can take time to establish rapport. They can interact socially and really pay attention to what the mother is feeling and experiencing. A good lactation consultant will treat breastfeeding as a relationship between mother and baby. They'll show empathy and understanding, meet the needs of the mother, that the mother feels and expresses. A good lactation consultant will normalize breastfeeding by encouraging the mother to tune into her body and her infant, expressing confidence in the instincts of the mother. And she provides affirmation during a time when the woman feels the least confident and most vulnerable. And at the end of the day, people won't remember what you said or did, they'll remember how you made them feel.
All right, perfect. I'm going to let the nursing students ask questions. First, if you have any, because I know you guys need to go. Do you have any questions? The quick group, we'll talk. But I will say, you know, I had the NICU, the new NICU nurses in here, and I was doing their fellowship teaching. I brought into one thing that I just learned from a patient of ours. This is her 4th preemie. And you really need to understand how words can make a difference. Her first preemie was born at Fairfax. That preemie is now 10 years old. when that mother had the baby, she was preeclamptic, so she was stuck on MAG and labor and delivery for 48 hours. She had a very severe case. She ended up being there longer for the 24 hours. Her husband had gone down to see the baby numerous times. Her first interaction with that baby was young with a preemie. You don't like to stroke, you like to just do firm pressure. Her first interaction with her baby, she was petting her baby like we do, you know, stroking the baby. And the nurse's word to her was, "You're hurting your baby." 10 years later, that still brings her to her knees. She felt like a failure during pregnancy, and then her first touch to her child caused pain. So remember, what you say to a mother can have a severe effect. This is one of my favorite patients right now. That kills me that 10 years later she still has that. So just be aware of what you're saying to a patient anytime that you go into nursing. That how is that going to be perceived by that particular individual? We do something in the NICU sometimes that, oh, we bring the baby to skin, and we might say, oh, the baby's not tolerating skin to skin, let's put the baby back in the box. How did the mother hear that?
Something wrong with your skin to skin.
Correct. Failed again. So please be aware. That one is, she's a very special patient. All of her children have had issues. So for her to have 10 years later, that would bring me to my knees.
Still hurts.
So, okay? That would just be my thought process. Her baby's very sick right now, so I'm having a little bit of compassion fatigue right now.
How old's the baby?
Baby is now 40 weeks. Yeah.
How old was you born?
28. So she has a 5-year-old with a G-tube in this one, and a kidney transplant to come. And this one's blood pressure's are shooting up, and possibly kidney damage on this one. She has 1 kidney to get, and 2 children. So be aware.